I'm the Director of Strategy at the Nuffield Trust, which is one of the health policy think tanks working across the UK. And I'm really delighted to have been asked to chair today's event. I've been involved in commissioning and providing mental health services for almost all of my career in the NHS, going back to the closure of the Longstow hospitals in the early 90s. And I think it's a fascinating area. I think if you break your leg, it's relatively easy to fix you. And you're a good plaster technician, good orthopedic surgeon, you'll be sorted. To keep people's mental health in good state is much, much more complex. And it's about the contribution of education, the contribution of housing, employment, many other factors in people's lives, as well as what mental health services themselves can do. So I think it's really excellent that the people in Surrey have got together such a great programme of speakers today to help you in Surrey think about what you need to be doing to make sure that the mental health of people in Surrey is as good as it can be. And I think today is just going to be the start of that conversation. It is a very full agenda. And so there is some important housekeeping. As I was saying earlier on, we will, as I finish speaking, ask everybody to turn their microphones off and to turn their cameras off so that we can be focusing on the speaker. We will make time for questions as much as we can do, but it is quite a full agenda. So the other thing I would ask you to do is to use the chat function. If you've got any points that you think are particularly important to note or any particular comments to make, but also to try and make sure that we don't have a kind of second conversation running in the chat so that we can still focus on what the speakers are saying. But it's a really good place to be able to make notes and contributions. And I will try and keep us to time as much as we possibly can. Without further ado, I know he's here because I checked before I started speaking. I'm going to ask Tim Oliver, the leader of Surrey County Council and also the chair of both the Health and Wellbeing Board and the Integrated Care System in Surrey, to kick off and talk about actually why this is such a priority for people in Surrey. So Tim, over to you. And as I say, people can please turn their cameras and their microphones off. That would be great.
Thank you very much, Helen, and good morning, everybody. Helen, you've kind of set the scene very well, I think, for us. I mean, this is a hugely important area and an area of huge priority for us at County Council and indeed for Surrey Heartland's health system. I think we've seen during COVID in particular and the lockdowns, a significant increase in people experiencing mental health issues of some sort. And it's become a much more visible issue and an issue that people are talking about, more openly than ever before. I wanted to just put it slightly into the context of the wider work that the local government have done and the health service in the sense of our 2030 vision for Surrey, and that is that no one is left behind, and that means addressing inequality of life expectancy, inequality of opportunity, and so on. And more recently, we've revised and refined that vision, and it was a vision that was contributed to by a huge range of partners, local partners, and key stakeholders, and I think is a very good vision and a very good roadmap for the work that all of our organisations need to do. But I think it comes down to 4 key areas now that are all intertwined, and that starts with actually having a strong and stable economy. Without that, that we're not going to ensure that we have full employment or that those that wish to work are able to work. And we know we've got significant challenges around the county, as of many other parts of the country, and here particularly around the aviation industry and so on. And we've had a very good piece of work done by the University of Surrey just to benchmark what the economy looks like here. And then I think that we know that there's an absolute interrelationship between a strong economy and health inequalities. Again, a tremendous piece of work has been done on COVID in terms of the community impact assessment. And it's really just highlighted, I think, what we already knew, which were the areas with high social deprivation and the challenges that those communities face, and that is absolutely what we collectively need to address. And partly to do that, that is about creating a greener future. It is about encouraging people and enabling people to access and enjoy our countryside. And Surrey has a fantastic green green spaces and countryside, which in fact actually the one positive thing, if there is anything positive about COVID, is that people have discovered those and experienced it. And we've seen a huge increase in people going out into the countryside. But we need to create a whole greener future, and the government have started to recognise that and actually put in some practical solutions to assist and to deliver that. And then finally, it's about empowering communities. I think that we've seen a phenomenal response in our local communities to COVID. We have we were supporting something like 40,000 vulnerable people over these past few months, and continue to do so. The vulnerabilities perhaps have changed, and the support that people need have changed. But I think we've actually seen neighbours talking to each other. We've seen roads coming together, villages, community parishes, towns, people really looking out for others. But underlying all of that, quite clearly, is the issue of mental health and the challenges that the people have in recognising it and then accessing the services that are there to support them. And there are. But clearly within Surrey, I mean, we have challenges around the delivery of mental health at the right stage. And I think a key part of the focus, both of the health system and of local government, is around early intervention. First of all, let's do whatever we can to prevent people falling into any sort of condition or chronic condition. If we can't prevent it, then let's get in there and intervene much earlier. And that means providing the resource and the capability in schools and when children are, when they first identified in having particular needs, special education needs, or indeed if there are mental health issues. So that has to be our focus, is on that early intervention. So I think this is a fantastic opportunity to get together people across the system, the ecosystem that we live in, and identify what we can do, how we can improve the services that are currently being delivered. Let's see if we can agree on what should be the priorities and how we're going to prioritize things, in terms of what do we need to do, what can we do practically, and how can we get a proper plan in place to do that. So it's a great opportunity. I'm a great believer in getting practical things out of this. This isn't just about talking through the issues. Many of you will be experts in those already. This is about a plan, a deliverable plan that will improve health outcomes for our residents, and in particular focus today on mental health. So Helen, I think I'll hand back to you, but thank you very much for facilitating this, and I look forward to having a good conversation during the course of the next couple of hours or so. Thank you.
Thank you so much, Tim. And I think you made a really important point at the end there, that today is about action. Although most of what we'll be doing today is listening to what our speakers have to say, what you really need to be doing is holding in your minds, what are you hearing people say, and how can you translate that into action for people in Surrey? And our next speaker is somebody I know from my personal experience of him is very action orientated. I think there aren't many health systems that can boast of having somebody who is both the former Secretary of State for Health and the current chair of the Health Select Committee as one of their local MPs. So I'm really interested to hear what Jeremy Hunt has to say from the national perspective about how mental health services and the experience of people with mental health might be addressed within Surrey. So Jeremy, can I hand over to you, please?
Thank you very much indeed, Helen. It's always slightly nerve-wracking when you're introduced by someone who used to work for you, and we work very closely together, because there's probably all sorts of stories you could be telling people, but actually we had a tremendous working relationship, and it's lovely to see you again, and thank you for chairing today's session. And a really big thank you to Tim, because I have never known this level of interest in mental health by Surrey before in the 15 years that I've been an MP. And it's a really, really important step forward for Surrey to take, because all the evidence is that if you're going to really make a difference in mental health, you need to get all different local services working together. If you look at the most extreme tragedy of suicide, you know, you've got to work with people in the transport system, work with people in the schools, work with GPs, work with the NHS. You've got to bring everyone together. But the evidence is if you do that, you can actually make a very big difference and bring suicide rates down significantly. But the same applies to all mental health services. So thank you, Tim, for doing this. It's a big thing to do, and I think enormously appreciated and respected. Nationally, there's been a big change in the last decade. I think 10 years ago, the feeling in the mental health world was that they were the poor relation to physical health services. And then in 2012, the Health and Social Care Act was very controversial in many ways, but the one thing that was not controversial was a clause saying that mental health and physical health should have parity of esteem, should be treated equally. And that might look like words, but actually it turned out to be a lot more than words, because following that, there then came a commitment from the government and NHS England that the proportion of money spent on mental health of the total NHS budget would always increase by more than the total NHS budget was increasing. So having had a number of years where the mental health pot was raided to fund shortfalls in other areas, that stopped. And there's lots more that needs to be done. But mental health is a very key part of the NHS 10-year plan. And indeed, when I was Health Secretary, one of the things I was most proud to do was to launch a green paper on children and adolescent mental health services and how we need to improve those. And we're still implementing those plans, but essentially that provides a very big new role for schools, a commitment that every school will have a mental health lead. And really that we harness teachers to be our radar for mental health problems, because they will generally know children better than local GPs. And it was a great example of the NHS and the education system working together, that the NHS actually recognised the vital role that teachers have to play. But just as the NHS has really started getting its act together in a big way, and there is a lot of extra money going into this, the world has also woken up to the power of mental health. And the challenge we have is that supply is going up, but demand is going up even further. And of course, what's happened with coronavirus has exacerbated that, because there are all sorts of coronavirus-related issues, from PTSD suffered by frontline health and care staff to the loneliness issues suffered by people isolating on their own for long periods of time, to the well-documented issues of people in care homes. And all these things have come together on top of the backlog that was created by the first lockdown to create extraordinary pressure in local mental health services, which Fiona Edwards, who runs the Surrey and Borders Trust, was telling me about this morning. So how do we deal with this mismatch between the services that people want and the services that we are wanting to supply and are increasing as fast as possible? I think there's really two keys. And the first is the prevention agenda. It's an insight for all of health that prevention is better than cure, but it's absolutely the case for mental health. And one of the most striking figures that I came across when I was Health Secretary is that half of all mental health conditions, half of them, become established before the age of 14. And so just think how much mental illness we could eliminate from society if we were to nip those early illnesses in the bud. And many people here will have heard stories of how young people that they know of developed mental illnesses that weren't picked up early or weren't addressed early enough, and then went on to become lifelong illnesses, instead of what can happen if you get something early enough, which is that you deal with it quickly. Sometimes you even cure it and it goes away for good. And so that prevention agenda is the biggest single change we need to make, because the problem at the moment is that the NHS has to focus its resources on the people most in need of its care. But too often that means that it has to turn people away with mild and moderate needs to focus its resources on people with severe needs. But it can't be right that we say to people, go away and come back when your conditions got worse, which I'm afraid is what happens all too often in the NHS today. And that's why it's so important that we expand the services that schools offer to give people access to mental health support when they have mild and moderate needs, and not always wait until things deteriorate. So the prevention agenda is the first. The second agenda that is equally important and linked to it actually is the well-being agenda. Some people say that we have not a national health service, but a national sickness service. I think in mental health, as our understanding of the issues around mental health is developing, we could do an awful lot more to help people become mentally resilient. A lot of the mental illness is triggered by the kind of personal crises in our lives that actually all of us are going to encounter, whether it's a bereavement or a marriage breakdown or something going wrong in your work life, or whatever it is. We're not all going to have all of those issues, but we're all going to have some of them. And helping people to prepare for those life crises is something that we don't, I think, do as much as we should. And people generally leave school with a pretty good idea of the difference between healthy and unhealthy food, but they don't generally or very often leave school or university with an idea of the few things that you can do, the habits that you can nurture in your lifetime to make sure that you're resilient for when those inevitable crises happen. And the result is that I think more people find that mental illness is triggered. So that well-being agenda, which is very, very important for the County Council because of your education responsibilities, is something that I also think we need to do a lot more thought on. But most of all, I just want to thank you for spending the time in doing this, and to thank Tim for organising it, because I think the more we do this kind of thing, the more understanding there is, the more we can be successful in preventing mental illness and tackling it when it happens. Thank you very much. Over to you, Helen.
Thank you. We've had a question posed in the chat that I wonder if you mind reflecting on, which is about the training of health professionals. And there's a couple of aspects to the question. One is, people are interested in your views on how we can encourage people to choose mental health as a specialisation in the first place, usually how we get mental health staff. And we've just done a piece of work in the Nuffield Trust about the factors that attract people or not to mental health nursing. And the other part of the question is more general about how health professionals in the round, whatever their circumstances, can have mental health training, and whether that should be a mandatory requirement rather than an optional requirement. So it'd be great to get your views on that.
Well, second one first. I personally think it should be a mandatory requirement because there's so much overlap between mental and physical ill health. So, you know, there's a much higher proportion of people with mental illness who end up having physical health problems. And when they end up going to A&E because of their physical health problem, actually what they really need is someone to look at the whole person and say, this is what we're going to do about your physical health problems, this is what we're going to do about your anxiety and depression and so on, and tackle it, you know, holistically. So I think it is very important that within medicine we break down silos and we equip doctors working in A&E and certainly GPs who are becoming much better informed and much more knowledgeable about mental health with all the tools they need to make sure that we can solve the whole problem in these situations. But I'm really pleased that you've asked about workforce, Helen, because this is the crucial, to use that horrible management jargon that's so popular, this is the rate limiting factor. There we are, I've used a horrible phrase, but this is the rate limiting factor to expanding the supply of mental health provision. It takes 7 years to train a psychiatrist. I see we've got Dr. Ben Spencer on the line, my excellent Surrey colleague who's joined the House of Commons as a Conservative MP, but has as a background as a psychiatrist, and he will have a lot to contribute to this discussion. But the truth is that we won't be able to properly expand the supply of mental health services until we have more psychiatrists, more therapists, more mental health nurses, and more of all the other different people that we need, the roles that we need. And because of that time lag, it is absolutely essential that we have a long-term workforce plan. And one of my disappointments at the moment is that the NHS has a 10-year plan, but they haven't put in that 10-year plan the number of doctors, nurses in every specialty that they think we'll need in 10 years' time, so that we can check that we're training them. And I increased the training places for doctors and nurses by 25% in 2016 and 17, which was one of the biggest ever increases. I was very proud to do that, but I don't actually think even that was enough. And that's why I think going forward, we need to have proper workforce planning. So in children's mental health, children and adolescent mental health, which I was just talking about, we have 8,000 people employed in CAMHS, and to roll out that green paper, we will need another 8,000 people. We'll need to double the size of the CAMHS workforce, although they won't all end up working for CAMHS. That's a huge issue. And that, I think, is probably the single biggest thing that we need to hold the government to account for, because without that workforce increase, we won't be able to meet any of our aspirations.
Thank you. I think some really important points about the workforce there. And if you wouldn't mind just one more, I think another point that's come up in the chat is the role, I think, a very unsung part of the less formal workforce, which is the role of carers. And be very interested, again, people would be interested in your views on how people in Surrey should be thinking about the role of carers and how carers are supported as we think about mental health services.
Well, two distinct issues here. First of all, I think we need to recognise that people with caring responsibilities and people working in medicine have a very specific and different set of mental health needs. Because if you are a doctor, a nurse, a social care worker, you are doing a job which is itself very stressful, because you're having to see a lot of people, often in a very challenging environment. But also as part of that job, you're having to give a lot of compassion and support. It's required by the job, and that creates a particular kind of pressure that other jobs don't have. And the NHS has announced, I think, some pretty good plans for improving the mental health support available to NHS workers, because we don't yet have a social care 10-year plan. We don't see that for the social care sector. But there's another group of people, Helen, which are also very important not to forget, which is unpaid carers. And these are the people who make an enormous difference by caring for friends or partners or loved ones. And I came across this a lot when I was trying to overhaul our services for people with dementia. What you realized was that often there was as much pressure on the partner, husband, wife who was living with someone with dementia, sometimes even more pressure on them actually, than on the person who actually had dementia. But if you focus your energy only on the person with the illness, then they are going to end up going into a care home, going into hospital much more frequently. And so you need to look at families and support units holistically and make sure that they all are able to access the mental health support they need.
Thank you again. Thank you for taking those two extra questions. I'm going to turn now to people within Surrey who are going to be speaking about the issues within Surrey in terms of what's driving the demand for mental health services, and really importantly in this conversation, what it's like, what the lived experience is for people who are experiencing mental health problems in Surrey. So our first two speakers are Dr. Helen Raisin, who's public health consultant within Surrey, and Dr. Negin, I get this right, Sarafaz Shikari, I hope, do correct me if I have got that wrong. And they're going to talk to us about the demand for mental health services in Surrey, and then going to hand over to Emma Wade, who's going to talk to us about the experience of being a service user. So Helen and Negin, over to you, please.
Thank you very much. And shortly I'm going to hand over to Negin, who's going to give the presentation itself, and we'll be focusing on insights that are specific to Surrey. But first, I just wanted to say thank you so far for the big push on prevention, because prevention, I think, is a really, really important part of what we now need to do in this county. So I'm just going to highlight a couple of things before Negin starts. And the first is that we're going to be looking at some estimated numbers here, but in mental health, like other conditions, but particularly mental health, we have a real pyramid of need. And many people aren't actually known to services. We've already heard a few reasons for that. But it may also be not just a lack of access or being turned down. It sometimes is choice. It can be stigma, either a felt stigma or an imposed stigma. So there are many, many reasons for that. But it's really important that at any point in time we realise that those people that we don't know about may become known. It might be because it's a personal crisis for them, or it might be in a time of national crisis. And I'm really pleased that we're able to present today some of the excellent work and insights around the mental health needs during COVID, which Tim rightly pointed out already have become more prominent this year, and we'll see that in the slides. And my final thing is also to echo one of the earlier presenters, and that's around social and economic inequalities. They do lead to poorer mental health. And what I mean by that is that the circumstances in which people live they're unequal. So whilst an individual from any background at all may have poor mental health or mental illness, it's the communities who are facing the greatest disadvantage who also face the greatest risk to their mental health. And with that, and an early call to action around prevention and tackling health inequalities, I will hand over to Negin, who's going to present the slides on behalf of our system. Thank you.
Thank you very much, Helen. So next slide, please. Thank you. So I just thought I'd give it over an overview of what I'm going to take you through my presentation. So we start by some of the kind of the baseline, if you like, of mental health state in Surrey before the pandemic. And I think some previous speakers have actually covered that. Then we look at the drivers of demand. Again, some of those already been touched, but it'd be good to kind of consider them in the context of Surrey. And finally, kind of impacts of COVID, how the COVID has actually impacted people. So that there, I would like to highlight the work that we've done through the community impact assessment, and also the impact on services. And finally, the actions that we have highlighted through these two important pieces of work. Next slide, please.
Can't see it. We can't see the slides.
Can you see it now?
No.
I can see them.
I can see them.
I can see them.
I can.
It sounds like there might be an individual issue.
I put my camera back on, but I can't see them.
Oh, that's a shame.
Can you send them at the end of the?
Yes, absolutely. We'll circulate it. I'm sure the slides can be circulated afterwards.
Okay, thank you very much.
Great. So moving on. So state of mental health before the pandemic. Next slide, please. So as Helen stated at the beginning, we've got numbers and estimates that can tell us or give us a picture in terms of what's happening in Surrey. So it is estimated that there are just under 130,000 people in Surrey with common mental health disorders. This number doesn't include people with severe mental health conditions. So when you consider those, the number tends to be much higher, probably between 130 to 140,000 people. So when you look at the data compared to the national average, there are some areas where we are red or where we can do better. So those are social isolation, particularly amongst adult carers, gap in employment rates in people with learning disability, and also those in contact with secondary care mental health services. Proportion of people using mental health services is also another area that we are higher compared to the national average. And finally, how we complete or record ethnicity data. And that is really important, and it's not exclusive to the mental health services. It's an area or issue that has been highlighted across all areas. And it's really important in terms of service redesign or when we think about improving access and uptake. Next slide, please. So now, children's mental health actually mentioned previously, so it is estimated, again, these are estimates, that there are just over 23,000 children and young people in Surrey with common mental health conditions between the age of 5 to 17. Again, compared to the national average, there are some areas that we are in red or amber. So all this data is available on the Public Health Fingertips profile. So if you and there's a link at the end of the presentation where you can access this data. So when you look at these areas where we can do better, these are percentage of looked after children whose emotional well-being is a cause for concern, hospital admissions for self-harm amongst 10 to 14-year-olds, but we also see that in other age groups, and percentage of school pupils with social, emotional, and mental health needs, both in primary and secondary school age. Next slide, please. So recently, there was a thematic review of probable suicide into adolescents, children, or adolescents people. And there are 3 key themes that I wanted to highlight here. Interestingly, most of them were known to services. Some had experienced adverse childhood experiences or had high risk behavior, risk factors such as drug and alcohol misuse or history of self-harm. Interestingly, some also had a medication, changing their medication in the last 4 weeks prior to their deaths. And I just have to highlight that this work was completed by our Adult Safeguarding Children Services in Surrey County Council. And there's a link at the end of this slide where you can see the full report. Next slide, please. So we talked about some of the drivers of demand on mental health services, and as this slide shows, they can be categorized in 3 different areas: so socioeconomic factors, system pressures, and resource. We talked about socioeconomic factors, particularly with the lens of COVID. We talked about economic pressures that COVID might bring, but also other factors such as substance misuse, loneliness, homelessness. And when you think about system pressures, again, we touched on some of those already. We talked about prevention and how important that it is to actually prevent people from getting into crisis. In terms of other system pressures can be also related to capacity of community services in terms of what they can deliver within the community, reduction in the number of inpatient beds, and lack of specialist provision and legislative changes. And finally, in terms of resource, we already talked about workforce limitation in mental health, high attrition rate amongst mental health practitioners. We talked about financial constraints and lack of investment in mental health services. Again, that was highlighted previously. But we all know that anxiety and worries relating to COVID will exacerbate all these pressures which are already under mental health services. Next slide, please. So if you put that in the context of Surrey, when we think about our vulnerability in Surrey, again, they can be divided into 3 broad areas: so clinical factors, social, and economical. So this just gives a broad indication, and there are intersectionality between all these factors that have been highlighted here. That gives a bit of context in terms of the scale of challenge that we are facing. And as you can see, they all actually touch on health inequalities in general. So these are vulnerabilities that we need to consider when we tackle kind of health inequalities in general, which relate to mental health inequalities as well. Next slide, please. So we talked about the community impact assessment previously, so it was a comprehensive piece of work, but for the purpose of time, I'm just going to focus on two key elements of that. One was the mental health rapid need assessment, and the other one was the temperature check survey that we did. Next slide, please. So both of those were looking specifically to see how the pandemic had actually impacted the well-being of people. So I start with the mental health rapid need assessment. So as part of this work, we did an extensive qualitative piece of work, conducted over 30 interviews and 3 focus groups, including one with mental health service users. So this slide just summarizes the key drivers or that actually impacted people with mental health conditions. And they've already been mentioned. So one key one was the social isolation due to the lockdown, where people lost their kind of connectivity with their family and friends. Their coping mechanisms, including kind of access to green spaces, kind of doing exercising, a fear of becoming infected, both self and family, conflicting information, particularly with patients with OCD conditions, where you're told to wash your hands, but otherwise being told not to. Ability to access care, and that was particularly an issue at the very beginning of the pandemic, where the system were in transition to remote consultation, and also working in frontline. What I haven't mentioned, but it's in the diagram, is patient with dementia. Again, they were one of the most people, particularly those that lived on their own, really impacted by the pandemic and by the local by the restrictions, and also the RBME population. Next slide, please. So these are just very summary, a brief summary of the temperature checks that relate to the mental health aspect. So 75% of people said that pandemic had somehow impacted their mental well-being. 52% of those, surprisingly, were between age 16 and 25, and 46 were from low income background, so that's under 25K. There was an increase on unhealthy behavior such as smoking and drinking, and also an increase in number of residents claiming universal credit or job seekers allowance by over 300%. And for many, that was the first time that they were making these claims. Next slide, please. So not surprisingly, our services were impacted as well. So there was an increase in out-of-area beds because COVID patients or wards were to accepting COVID patients were prioritized. There was a reduction initially in the number of referral into the services, community services such as IAPT, but then an increase in our community volunteer sector organizations, where they kind of were picking up a lot of calls and asked from the local residents. The cases became more, as the time went on, cases became more complex, which probably related to other issues such as domestic abuse or other socioeconomic factors that were impacting people during the lockdown. And also mental health of our workforce was particularly affected. So the diagram on the right-hand side describes some of the key stresses or psychological impacts. This is not from our local data, but from a recent literature review that we did that is likely to be applicable locally. So as you can see, anxiety, depression, post-traumatic syndrome, and moral injury, which is another kind of psychological stressor relating to not being able to do the best for your patient, were highlighted in this literature review. Next slide, please. So what we're doing about this. So the recommendations that came through the rapid need assessment are described in this diagram here. So we talked about clear communication already. A lot of people felt that if they knew how to self-care or access care, that would have helped them to a great extent. Prevention of mental ill health, again, we talked about that and how important it is to prevent people getting into crisis. Building capacity, so we talked about that already, again, about services, workforce, but also our community sector organizations, because they are really closer to the residents, and they are already picking up a lot of that work. Improving access to mental health services, including self-referral, self-care, and really addressing the health inequalities, not just mental health inequalities, as they're all interlinked. And finally, increasing our partnership, working together. And I think the pandemic has helped that to some extent, to a great extent, actually, in terms of people coming together to drive, the agenda with a common goal. Next slide, please. And I can give example of that. So one of them, there is the mental health reference group that was set up, I think, at the very beginning of the pandemic. It's a multi-agency workings attended by SABP, IAP services, public health, adult social care, community sector. And these are the key areas that this working group is working on. And as you can see, is not just recovery, but also responding to issues and addressing health inequalities. In addition, we've got the Suicide Prevention Partnership, which is looking at implementing the key 8 priorities relating to suicide prevention. And again, that has been ongoing for the past 10 years, but strengthened over the last few years. Next slide, please. So that is from me, but I'd really just like to acknowledge a few people here. First of all, our residents and service users that really helped us to gather this insight and information together. Our stakeholders, because a lot of them actually took part in this interview, but also help us to shape our agenda going forward. Also the Surrey Insight and Intelligence team that put the survey together, and they were key players in putting out the community impact assessment together. And of course, my team, my public health team that has been working flat out throughout this pandemic and also really helped me with this work as well. Also Surrey County Council Tasking Group on Mental Health. And I think that is from me. If you go on to the next slide, these are the references that I use throughout my presentation, but I'm sure they'll be circulated and you have access to all of those documents. Thank you very much.
Thank you so much. It was really helpful and information and detail in there. And we're now, as I said earlier on, we're now handing over to Emma Wade, who's going to talk to us and I think ask us some questions about the experience of people who are using mental health services in Surrey. So Emma, you're very welcome. Over to you.
Hi everyone. I'm Emma. I'm a CAM Chief Advisor and current service user. So I'm basically going to be taking you through an exercise called How Do You Feel? So there's a series of statements, and at the end of each one, I just need you to think about how you would feel if you were in the position of the person reading these statements. Next slide, please. Yep, so that's what, and next one. Okay, so from infant school, you experience bullying through school. How do you, how do you feel? Sorry. 6 years later, at 13, you have no friends and have become extremely anxious and depressed. How do you feel? You're taken to your GP by your parents who are concerned about your health. How do you feel? You have started to see a school assistant 6 months after your GP visit, having received no further information on what help you can be given. How do you feel? You have started self-harming daily to deal with your feelings and the bullying that you are experiencing. How do you feel? You're reported by a school teacher after self-harm wounds have been seen. Your parents are informed for the first time. You are taken back to the GP and referred to CAMHS with a suspected diagnosis of anxiety and depression. How do you feel? Over 18 months later, you are still on the waiting list for CAMHS with no support in place. You have stopped eating properly and have been rejected twice by the Eating Disorder Service. Your self-harm has become worse, often multiple times a day, and you have started to experience suicidal thoughts. How do you feel? Two years after your referral, you were taken into hospital following a suicide attempt. You are re-referred to CAMHS and have an assessment. You are rejected at the assessment and are redirected to a charity and put on another waiting list. How do you feel? A month later, you are taken back into hospital, unable to walk or talk. You've lost 18 kilograms of weight in 6 months and have not eaten in 5 days. You are taken into the eating disorder service where you must be treated before you can start any treatment with CAMHS. How do you feel? After 9 months under the eating disorder service, you finally have your first CAMHS session over 3 years from your first referral. You stay for 2 years until you're discharged at 17 with no transition plan. How do you feel? A year after your discharge, you are taken into hospital following another suicide attempt. You are diagnosed with borderline personality disorder and are taken on by the CMHRS. How do you feel? "11 months pass with no treatment or therapy. In this time, you are hospitalised and cared for on and off by the home treatment team. Finally, you have an assessment and are deemed suitable for CBT therapy. How do you feel? Thank you for taking part. A lot of the comments that kind of came up were a lot of hurt, hopelessness, confusion, anger, and that was actually my story, and that is a lot of what I did feel. Obviously, my journey has been years and years long, and from everything, I think for the biggest thing that for me could have been improved is the early access and the early intervention, which I know has been mentioned already throughout the presentation. Obviously, it was just over 3 years from my first referral from my GP through to when I had my first CAMHS session, and even with the eating disorder service, I had 2 referrals there which were then rejected before, and what I found for me with the services is I had to be really, really unwell to be looked after and to receive any treatment. And that was through both the CAMHS, and I've also found it in the adult services as well. When I was in CAMHS, the treatment that I did eventually receive was really good. I'm yet to meet a nurse, a doctor, a psychologist, psychiatrist, hospital worker who hasn't been nice and hasn't been understanding. But for me, it's the way that the services are working at the moment. I know I'm not the only person in this kind of position. So yeah, for me, I think early intervention and what I found caused a lot of the feelings of kind of confusion and hurt and feeling like I wasn't good enough for treatment. I had a lot of being told that something was going to happen and then something not happening. So being told you have a referral, you will hear back, and then 18 months later having no support. The other thing that I think would have really helped in my journey is proper transition, which I know is something that is being looked at to be worked on. I was discharged at 17 because I was nearly 18, and they basically said that they were worried that if I went into adult services, it would be very hard for me to come out of the services, so I was discharged. But I was discharged with no other support in place. I went from having been seen kind of like weekly for 2 years, 3 years if you include the eating disorder service, to having absolutely no support around. I was at college at the time and did try to go through college, but unfortunately the services within schools and colleges and universities aren't quite there yet. So obviously I did then end up back in adults anyway. In terms of COVID, that's definitely had a big impact on me, and I know a lot of other young people and adults in services, or who generally struggle with their mental health. I've had probably the worst 6 months in terms of my mental health through the first lockdown, and I think the not having enough access to care obviously it had a big impact on the long wait that I've had before I've then been able to access any care. So that's what I kind of feel is working well, what worked well for me, and the things that I think could have the most improvement. Thank you.
Thank you so much, Emma. And I can see from the comments in the chat how much people have appreciated the story that you've told us and sharing your experiences with us. And I think it's such an important reminder for us that we're not talking about theory today. We're not talking about principles, when we are a bit, but actually we're talking about principles which are about real people.
Yeah.
And this is about thinking about how services in Surrey can be better for people like Emma, for Emma's family, and for everybody around her. And I think we're now going to move to a couple of videos before we have a short break. So again, I think this is about people's real experience.
Especially is Edmund O'Leary, and I have a lived experience of mental illness, especially long-term depression and post-traumatic stress disorder. This has affected my life for a good 20 years plus. My consultant psychiatrist signed me off his books about 18 months ago, thinking that I was, I guess, a success story, and my mental health could be managed by my GP, who I have never met in person because it's a new GP. I became very isolated, and I became very lonely, living on my own. Used to receive a full package of support from Surrey and Borders Partnership, and that even included having a support worker visit me for 3 hours a week, which was of huge benefit. But sadly, as I am no longer a patient of Surrey and Borders Partnership, I have no package of support, which has not helped me one bit. The only support I have is the support of a GP, and I've never met the new GP in person. I've just had one telephone consultation with her many months ago. I am currently on Universal Credit. It's not something that makes me feel proud, but the reality is the Universal Credit payment I receive pays for my rent and pays for a few bills. The lockdown this year has been a complete nightmare for me, and I have ended up earlier this year mentally ill. And although there has been some engagement between me and Rosebery Housing, I believe it has been quite lackluster. I have found it very difficult to get work. Employment is not all about making money. It's about playing a role in society and feeling valued. On the run up to Friday the 16th of October 2020, I was feeling very low, and I was feeling very depressed, and I have to say earlier this year I had considered checking out. Thankfully I haven't checked out, but I did decide to put a tweet out on the 16th of October just before midnight, just saying I am not okay. I am feeling rock bottom, and if you see this tweet, it would be lovely if you just say hello. 20 million people have seen my tweet, which is surreal, and I never expected that. 102,000 people and counting engaged with me directly. Photographs of cats, kittens, puppies, small human beings, big human beings, anything you like. I'm absolutely delighted to say that one of my new friends is Matthew. He connected with me on Twitter, and he invited me to join him on a walk. And his approach was very welcome and right up my street, because it was very personal. He's a lovely guy, and I accepted his invitation. And I really valued that one-to-one connection over Epsom Downs. I have to say, I have to laugh, because when I reflect on my first outing with Matthew, I thought it was going to be a gentle stroll around Epsom Downs, and I soon discovered it was an introduction to army training. And I think this is a good time to, I suppose, remind the powers that be that although group activities and group walks are fantastic and have their place, they do not suit everyone, and there is a need for sometimes one-to-one walks as well. Perhaps not one-to-one army training, but one-to-one walks are very very beneficial. I feel the Mental Health Trust could be far more proactive in terms of reaching out to people who are on their books or people who have recently been signed off their books. I really feel that we could do with far more carrots and far less sticks, because the sad fact of the matter is the regime, certainly prior to COVID-19, is more a regime that punishes people than a regime that rewards people, especially in terms of sanctions. And the story is not over yet.
So I can see from the reactions in the chat how much people appreciated Edmund's story as well. And I think some very important messages there for the services, but also I think some very important messages for us all as individual human beings. Actually, almost no action is too small. You know, people took some very small actions and it made a huge difference to Edmund's life. So really important for us as individuals. We're going to take a short break now. Don't leave the meeting on your computer. You know, keep your camera off and go make a cup of tea, but stay in the Zoom. And we'd like everybody back here at 12:55 sharp, when we're going to hear from some international perspectives from Mark Britnell. So just say 10 minutes, put the kettle on, go to the loo, and we'll see you back here very shortly. Thank you. To introduce Mark Britnell, very long-serving health policy person, long-serving in the NHS, and then even more perspectives from around the world in his role with KPMG. And Mark's going to be talking to us about some of the experiences that he's been learning about in Australia. So Mark, over to you.
Okay, well, thank you, Helen, and good afternoon, everybody. I've been on the call since the conference started, and been very moved by the last two speakers in particular. I'll be joined today by my colleague, Dr. Charlotte Refson, who is a general practitioner as well. Next slide, please, Charlotte. And the next one after that. I'm going to talk today about the importance of employers in promoting well-being. I know we have 113 participants on the call this afternoon. And I know many, or if not most, of the participants are drawn from the public or the public sector, the wider public sector at large. And as Jeremy said at the beginning of the conference, solving this wicked issue, this wicked problem, requires the mobilisation of all assets in society. And I wanted to present some work that we've done in Australia. The parallels are very striking. And we have done over 2 years detailed work with Mental Health Australia, looking at how motivating employers and businesses is also fundamentally important to promoting and protecting mental well-being. Next slide, please, Charlotte. Before I dive into our findings, which are supported by the findings of the World Health Organization, I thought I'd just recommend a book from my old friend and former boss, Lord Nigel Crisp, who was the former Permanent Secretary and Chief Executive of the NHS. And I had the pleasure of contributing to this book, and it's called Health is Made at Home and Hospitals Are for Repairs. And as you can see here, two quotes, one from Nigel and one from myself in the book. And I think this is a truism. The NHS can't by itself deal with many of today's major health problems, such as loneliness, stress, obesity, poverty, and addictions. And as I started to think about his book and support his book, I have come to the conclusion, as I say here in the quotations, that no country will have a sustainable health system unless it harnesses all the assets in society at its disposal for health creation. So specifically, we're going to look at the role of employers. I know I'm being followed by the Chief Constable. We've had Jeremy speak. I know there are parliamentarians participating today. But next slide, please, Charlotte. This is the size and scale of the problem. It's a very busy and colourful graph, but it shows you basically the share of population with a mental or substance disorder into male and female. And you may just see the light dotted line that shows you that actually there is sadly a higher incidence of mental health problems with the female population. And you can see right at the top of the slide or the graph, the far right-hand corner, that Australia has a higher proportion of both males and females suffering from mental health problems than any other country. Now, I have written in my first book, In Search of the Perfect Health System, that actually, in my opinion, having worked in 80 countries, Australia has one of the finest mental health services in the world. So I don't think this slide necessarily tells you which country's the worst. It may show you which countries are actually surfacing and identifying these problems and hopefully tackling them more quickly. But as you can see here on the left-hand side of the graph, the World Health Organization estimate that nearly 1 billion people globally live with a mental health disorder. That's 13% of the entire world's population. And the point I want to make here is there is a clear return on investment in terms of tackling mental health early. As we've said before, promotion and prevention is indeed better than treatment. Next slide, please, Charlotte. Sadly, and we just heard, I think very powerfully from the last speaker, that COVID is really put more pressure on a service that's already under tremendous pressure. You can see here that 93% of the 130 WHO member nations have seen mental health services disrupted or halted since the pandemic started. That really genuinely is quite foolish and sad to learn. We also know that people with pre-existing mental health disorders are more vulnerable to COVID. And of course, COVID can lead to greater neurological and mental health complications, especially with long COVID now being a recognized clinical condition. But perhaps a little bit more optimistically, 70% of countries through the WHO survey have seen that telemedicine can overcome some of the disruptions. But of course, depending on the country and the internet penetration, access does vary. Next slide, please, Charlotte. Now, this is the work that I was asked to present on today. We, along with Mental Health Australia, who are the preeminent mental health organisation down under, committed to 2 years' worth of work where, in detail, from the bottom up, we looked at the cost of poor mental health and well-being in employment. Now, I know there are many issues about people with mental health not having employment, and I'll come back to that in a moment. But you can see here from the work of the WHO, first of all, before I move to the graph, that nearly $1 trillion each year is lost in global productivity due to depression and anxiety disorders. And it may surprise you to know that 57% of all days, working days, lost to sickness are related to mental health. Now, the WHO reckons there is a £1 or $1 in and a £4 or a $4 return in investing in mental health. And what we did over a 2-year period working with Mental Health Australia and many of the small, medium and large employers in Australia is we looked in great detail at the numbers, the facts, and also the solutions. So you can see in this graph here that basically having a stock of unemployed people who are mentally unwell is bad enough. But then there is the issue of sickness, absenteeism, presenteeism, and you can see the chronic effect of poor, mild, moderate and severe mental health on productivity over a 20-year period. I should add that although these percentages may look small to you, as you know, the UK, even before a deal or no deal Brexit, its productivity levels were the lowest in the G7. And this quote here from Mental Health Australia, once again, underlining or emphasising the importance of improved mental health at work because it improves productivity. And you can see here that they say productivity improvement will be the primary determinant of income growth in the future. And that's certainly true. So let's look at the detail. And I'm going to ask Charlotte to say a few words in a moment or two about our detailed findings. But next slide, please. So this is the report that I had the honour of presenting in Sydney back in the winter of 2018. So the report's a year, 2 years old, but the numbers are pretty consistent. So as I said, the World Health Organization did a top-down guesstimate on the return on investment for investing in mental health services, but we did a bottom-up granular cost assessment. You can see here that we've estimated for Australia a population of about 25 million or so, so just under the population of the United Kingdom, that a $4.4 billion investment, it's not so much money, saves up to 12.7 billion in the longer term. So this means actually there is a return on investment of 1 to 3, still incredibly attractive. And of course, the point of my presentation today, and I don't think there are too many business people in the audience, I noticed a few organisations that perhaps represented employers or were large employers themselves in the private or the independent and charitable sectors. But you can see here that we require, once again, a whole system intervention where government, health services and industry make investments. And the reason why I think this conference needs to reach out into business locally in Surrey is because the biggest single saving or benefit for early intervention in terms of improving mental health and well-being is actually in the workplace itself. So let me just go into, so remember the figure $4.4 billion of investment, and remember that it will return 12.7 billion over a period of time. Just remember the 12 billion number. Next slide, please. You can see here, and we're condensing a 60-page document, which we're more than welcome to share with you. But the 60-page document talks about 3 broad recommendations and then goes into detailed actions in terms of realizing the benefits to individuals, to organizations and society. And you can see here through the red hoops that when the single biggest saving is to improve workplace mental health and well-being, When you look then at the second issue about housing, which I think a couple of speakers have mentioned, you can see that there's a saving of 1.6 billion. And then finally, as many speakers have said, actually intervening early on is certainly the best for the individual and society and the economy as a whole. Now, when you add up these figures, the 4.5, the 1.6 billion, which actually increases to 4.8 billion in the long term, and the final saving of 1.6 billion, 75% of the benefits of investment can be realised through these three actions. And certainly in my global travels, when I've been working with organisations around the world, it is very easy to become distracted in terms of prioritising actions which align to a true north, if you will, if you like. So workplace well-being will return significant savings and benefits to individuals in the economy. Housing and homelessness, especially amongst the young, between the ages of 15 and 24, will yield brilliant savings and a return on investment. And then the early interventions that many people have talked about also produce great savings. Now, before Charlotte takes you behind this slide in a bit more detail, the report itself was supported by the equivalent of the Confederation of Australian Industry, or in our case, the CBI, and we worked through in detail with employers and their strategies, good and bad or indifferent, to make sure that we fully costed and appropriately costed the intervention, the benefit, and the investment that was required. So if you like, to paraphrase the entirety of this presentation, we've created a business case for business to engage with health and government in improving mental health and well-being. Now, Charlotte, just take our audience through in some detail the next couple of slides, please. Over to you.
Thanks, Mark. Could you forward to the next slide? Thank you. So this is a double click, if you like, on that top level, that first recommendation about mental health in the workplace. And in particular, that first recommendation 1.1 about workplace interventions. And I just wanted to give you a feel for the kind of evidence that we went through and the methodology we went through to get this evidence. So in producing it, the report, they looked at a range of resources through from mental health data, past reports and inquiries, a literature review and a stakeholder consultation. And they looked at interventions at both the kind of primary prevention, secondary prevention and tertiary prevention level. And I'm just going to talk through some of the most effective. As you can see here, they've sort of qualified them by the quality of the evidence base and also upon the effectiveness of the outcome. And I think the three that I would pull out and draw your attention to were within primary prevention, the job control. So the ability to decide for yourself how, when and where you work has a moderate quality of evidence and has a very effective outcome. Within the secondary prevention, the CBT-based stress management has a medium quality of evidence and has a high quality of evidence and very effective outcome. And in tertiary, you've got the PST, which is problem-solving therapy for those who are returning to work after a mental health absence, has a moderate evidence base and a very effective outcome, and was actually supported in a 2012 Cochrane report. Could you just go on to the next slide? Thank you. So as you can see, if you compare the return on investment, which is along the bottom for all of these different interventions, you can see that they all have positive impact as in terms of an economic return on investment, although some more than others. With the highest there for the problem-solving therapy, and at 4.7, whereas CBT has got a return of 1.7. But that's not to say that the impact of the PST is more than the CBT, because if you consider the number of people that is going to impact, it will be different. So the report actually did a an example and said that if you applied PST to around 10,000 people, it would cost 5 million and give you a return of 26 million, and that's Australian dollars. Whereas CBT, which has a smaller ROI, but would probably impact more people, if you applied that to half of the working population, it would cost 1 billion Australian dollars, but give you 2 billion Australian dollars in return. So of course, I'm not saying that this is the same, that the economic return on investment is the same as clinical effectiveness. But by the way, all of these are shown to be clinically effective, but it does provide, it sheds new light on a problem through an economic lens that can help you make complex social decisions. Thanks, Mark.
Thanks. Next slide, please. That was great, Charlotte. Thank you. And then turning into the UK, obviously with the Work Foundation and the Mental Health Foundation, we know that about 40% of working age adults were in employment who had a mental health problem, compared to 74% who work without a mental health problem. And we also know, as we heard, I think, from the last speaker so powerfully, that 85 or 90% of people with a mental illness who are not employed say they would like to work. And we know why, as you can see from the quote in the blue box. And even if we couldn't persuade business to engage with us, but I do think, as I'm going to show you in the next slide now, many even hard-nosed businesses will want to participate. This is just a screenshot from my own organisation, which employs 225,000 people across 157 countries. And I'm responsible for about 45,000 of those staff in different parts of the world. And we are now, we've actually developed 2 different services, as well as the usual reach out and connect services that I think most good employers now are encouraging. But if I take you now to my last slide, and this is something I think, given the relative prosperity of Surrey in terms of its being an economic powerhouse as part of the Southeast, I'd like to just end with a real example. And this is my point today, by the way, that we have, you know, over 100 participants on the call, very powerful alliances between local government, local society, the health service, and obviously Jeremy speaking at the top of the conference. I think it's an opportunity perhaps for health to support business, perhaps even encourage them to buy services from the NHS. And as you can see here in this example with the City Mental Health Alliance, which is obviously a not-for-profit organisation, you wouldn't think that perhaps hard-nosed financiers or hard-nosed bankers working in the City of London would give 2 hoots about mental health and well-being. But of course, burnout, stress and anxiety is enormous in the square mile. And KPMG, we're very proud to be one of the founding members of this alliance. And you can see here now that it provides expert mental health support for businesses. It provides standards and benchmarking for organisations that want to improve. And it also provides direct support in terms of training and education. And just as I finish now on my last slide, as I'm coming up to the 20-minute mark, next slide please. I was pleased that Jeremy recognised that workforce was one of the issues that sadly escaped his tenure as Secretary of State. But as some of you will know, I've recently published a book called Human: Solving the Global Workforce Crisis in Healthcare. And many of the themes about good employment extend not only to people with mental health problems or issues, but frankly, should just be part of a good employment package and offer. And so in conclusion, I am delighted to participate today. I think the seminar and the summit that's been organised is wonderful. I think there's an opportunity to potentially reach into or reach out to business. And I certainly think they have a big responsibility to look after their own workforce, because it makes good care sense, moral sense, ethical sense, as well as being good for society and the economy as a whole. There is a clear business case for business take mental health more seriously. Thanks very much indeed, Helen.
Thank you so much, Mark. And I think it's also worth us remembering that the NHS and local authorities are themselves big employers, and often the biggest employers in an area. So, this is not just a message for some business out there, it's a message for ourselves as employers as well. Mark, if you wouldn't mind, there is one question in the chat, and we've got a couple of minutes that I'd be really interested in your views on. And it's essentially saying that people can have difficulty getting work in the first place because employers don't look at people's abilities. And I think of myself when I'm recruiting. There's a bad tendency to look at qualification, past experience, rather than what can somebody actually do, what are they capable of doing. So how do you think employers could be encouraged to see value in a different way and to think about different parameters when they're recruiting?
Well, I mean, I think there are two quick answers to that question. I think the most progressive employers now are, obviously in terms of their recruitment processes, using anonymised forms of recruitment to weed out any subjective or objective bias or discrimination, and whether that's because of race or sexuality, religion or health status. I think we've seen a number of organisations, including ours, by the way, where we've been, I think, identified as one of the top 10 employers in around the world. We now move to a much more progressive, I think, a form of recruitment. I think in terms of then looking at skills, as we've just heard from the two speakers that spoke so courageously about their own mental health issues, that the wealth of experience that people who are living with or have improved their well-being through their struggles with mental health, I think makes them much better employees because of their perspective, their reflection, their wisdom, and the support that they can give to others. Now, we're a long way yet from recognising, and no one would wish to have a mental health illness to become a better worker at work. But I think as far as I'm concerned, the more that we can talk about these issues, the more, of course, they can be supported and appreciated. But I think for people who have been through mental health disorders, the wealth of experience they have and their ability to help others, I would see that as a very valuable asset in any workplace.
Thank you, I really appreciate that. So we're going to hand on now to Chief Constable, to Gavin Stevens. And we know that there are some really significant issues about the way in which the police service interacts with mental health services and with people themselves who have mental health issues. So Gavin's going to be talking to us now about how the police perspective on demand for mental health services and the support for people with mental health issues in Surrey. Thank you, Gavin.
Thank you, Helen, and I'll do my best to continue some of the themes that Mark started as well. So really good to have the opportunity to share a police perspective on this afternoon. Also on the conference is Lee Sawkins, who's our lead in this area. So if colleagues want to connect with Lee, you'll see him in the attendees and can no doubt exchange messages on the chat panel or contact details. I just want to give an overview of some of the acute demand that comes into policing services in relation to mental health. Maybe then some thoughts on the implications for service design and what that means for each of our individual services and what we might be able to do better together, or indeed better with our communities. And then also just briefly at the end, a little employer's perspective, which picks up on some of the things that Mark was saying. So if we could move to the next slide, please. So there's lots of facts and figures in what I'm about to go through. I won't dwell on them because I know that we've got a report that we can circulate to you all, and you can browse the slides in detail, but you can see at a glance there just what's been happening to the demand coming into policing over the course of the last months over the sort of COVID crisis. So if you take the figures there for September, over 1,700 mental health incidents reported to us. And of course, each and every one of them could be a story like Emma's earlier on. People often in an acute crisis that turn to us at particular times, sometimes when they're finding it difficult to access other services. If we move on to the next slide, which gives an indication of where we then have to use coercive powers to take people into custody under Section 136 of the Mental Health Act, of course, something that we never really want to do, but often is necessary to do for their own safety and for others' safety. But I suppose this is an indicator of the where things have got really serious, and it needs that sort of coercive intervention. And again, you can see what's been happening over recent months through the summer and into the autumn. The one that I guess concerns me most is the second line on this slide, where we're talking about taking young people under 18 on section 136s, and you can see that from just a few each month. We've had a few months now where we've had to do that with 8 of our young people across the county in each of those months. So a really worrying trend that's starting to emerge there. We know that this type of demand is not at all specific to Surrey. I sit on a local policing coordinating committee nationally, and the National Mental Health Lead reports into that. And these are the sort of trends that we're seeing across all of UK police services. And as a number of contributors, Dave, have pointed out, things have really been exacerbated during the pandemic. The next slide shows a little bit more about where I think we need to think in terms of service design. So this is just the same information but broken down by hour of the day. And of course, you can see there for the 2021, the sort of orangey, peachy coloured bar chart, the previous year in blue. And from sort of 9 o'clock to 10 o'clock at night is where we're seeing the peak of those sort of cries for help, if you like, coming into policing. Sometimes from the individuals themselves who are in crisis, sometimes of course from people who spot them on the street or on our road networks, or by their sort of neighbours and local community members too. So there's definitely something there for us as a collective about our services, as to how we get that provision available at those hours of the late evening. The next slide just gives a little bit more of a breakdown in numbers and some of the sort of causal factors, as it were. So this gives a summary across the county, some of our boroughs and districts, so we can start and get more specific about where we're seeing the increase in demand. I was actually looking at this the other day alongside some of the economic impact of COVID in the boroughs that are most affected by that. We know Spelthorne, for example, has seen a big impact. We're seeing that in these figures. Now, whether there is a causal link, whether they're related, I don't know, but it was interesting to me that there are a couple of boroughs that really sort of stand out there as a shift in demand this year. And there's some sort of insights there around effects of substance misuse, for example. And of course, we've spoken about the issue with young people. I mean, the costs Mark explored in much more detail, the business case, if you like, for investment, some of the impact of the acute costs you could see there, and this is money that I and my colleagues would much rather be spending on preventative work, much rather be spending on community interventions than having to deal with it when it gets to the point of a acute crisis. So the next slide starts to talk about some of the response to this, and I guess this is where I'd like to take the debate and the discussion about what are the things that we could practically do differently in terms of our service design across different agencies. So we know we've had our joint response unit running in Guildford, which is a collaboration between Surrey Police and South East Coast Ambulance Service, where you've got police practitioners and mental health practitioners working together to be able to provide that joint agency response on the street, and we feel that's of great benefit, and we're looking at where else we could maybe make that service available. And the north of the county, particularly when you think about those figures in Spelthorne, certainly is of real interest to us. we do much more on a training point of view now. I'll say a little bit more about this towards the end of the slides, but I really applaud the sort of greater level of awareness generally in society, but particularly amongst public services about the importance of early intervention in mental health. So initiatives like mental health first aiders, champions, having training that's accessible to all of our new recruits that they can apply on the street just a few weeks later is really important. The other thing that I think shows us real promise is the Surrey High Intensity Partnership Programme, where we do some really intensive work with those members of the community that may be accessing many of our different agencies and different services on a repeated basis, to really try and get underneath what those causal factors are and what we can do to help solve the problems. And we've got a proposal to run a pilot for a younger age group now, which has been agreed by all agencies, which is really, really welcome. I saw some of this in practice myself when I went out with the Joint Response Unit on a New Year's Eve shift, where the crews, both from a policing and a South East Coast Ambulance point of view, had a care plan in their possession on their mobile phone before they got to the address. The quality of the interaction as a consequence of that was markedly different to had they just been walking in blind and not had access to that type of information. So the joining up of our systems to make sure our practitioners are really, really well informed, I think is essential in making sure that we're giving the best service that we possibly can. My final slide, just I wanted to talk a bit about the sort of opportunities that are available to us. So we do have, as I say, Lee, who leads on this sort of full time for us. We've also introduced, I'm grateful for the funding support on this from Public Health, the suicide prevention lead as well. Yesterday, I spent a little bit of time, just dropped in to see our colleagues in East Surrey Domestic Abuse Services, and they were talking to me about how they've lost some of their clients who have completed suicide over recent months during the pandemic. So that work on suicide prevention, I think, is vital for us all too. But what struck me, listening to all of the contributions so far, is that if we're to make real progress on this, it can't be something that's done either by an individual agency or even the collection of agencies together. And I guess the analogy I would give is that policing is not really done by the police. Back in 1829, when the Peelian Principles were set out for Sir Robert Peel by Charles Rowan and Richard Mayne, one of those principles talked about the public are the police and the police are the public. We're just simply paid to give full-time attention to the duties incumbent upon all of us. So this idea of community safety coming from everyone within our communities and not just the police service, I think we've got a strong 200-year history in that, and we work very hard on that sort of policing by consent approach. And it struck me that with something like mental health, that sort of whole community, whole system approach is really important. And it reminded me of a TED talk that I watched quite a few years ago now by Vikram Patel, Mental Health for All, by All. And in that, Vikram talked about if there are 450 million people or so across the globe who need mental health support, maybe 50% of them in wealthy nations may be able to access professional support, but in poor nations, maybe only 10%. So Vikram's proposal in that TED Talk, which is, I think, well over a million views, was about unpacking the interventions that are done by professionals and making them available to members of the community to do in their everyday interactions with others. And I think we heard that in one of the testimonies earlier about reaching out for help and going for a walk and getting involved in exercise. And so what is it that we can do at a really early level, at a community level, to inform people about what are the right things to do at that stage that may help us all out. Yeah, I'd be really interested to explore that idea and how it could be tiered. So things that are available to our communities, things that are available to frontline practitioners such as police community support officers, to police volunteers, to give them that insight and that extra level of skill, so that we can all offer something of value. And of course that needs to, I believe, happen in the workplace too. I'm a trustee for a charity called Police Care UK. It's a local Surrey-based charity, but provides national services to help police officers, staff, volunteers recover from trauma. We know that police experience trauma on a regular basis, sometimes daily. And there was a study done by University of Cambridge with Police Care UK called The Job, The Life, that identifies that as many as 1 in 5 colleagues will have some symptoms of post-traumatic stress disorder. So we're working at a national level and with the National Police Treatment Centre up in Harrogate to design interventions that can be done by first line supervisors and managers and colleagues to help colleagues deal with that as and when it happens, immediately after it happens, and to get things back into perspective in order to continue to lead a happy and healthy policing career where we can see the good in things and deal with the trauma that we encounter on a daily basis. So I entirely agree with what Mark was saying earlier about the responsibility of employers in this, and it was really interesting to see the slide that showed the evaluation of the merits of the different approaches to that, which is certainly something that I'll be picking up as a consequence of this talk. So the final slide here shows this conference that want to explore any of those with me or with Lee or any of the team that work in this, then we'd really be delighted to continue those discussions. And I think we've got a few minutes if there are any questions. So thank you, Helen.
Thank you, Gavin. And there was quite a bit in the chat about safe havens and the role and the value that safe havens can play. And question for you about whether you see a value in those being available 24 hours a day.
Yeah, whether it's 24 hours or whether it's certainly late into the evening. Another indication of that was during the pandemic, we also started a digital 101 service. So this is 24/7 monitoring of all of our social media channels in our contact centre. So whether that's publicly posted messages or direct messages sent to us on any of the social channels. What we found through that, as well as it being a really welcome service to our communities, was that quite a number were contacting us for what I would describe as befriending. They didn't, when the chat started, they didn't really have a policing need or requirement that they were after, but they clearly had a need to reach out and feel contact with somebody. So we've been talking to the team about whether we expand that service with support from some volunteers and befrienders that can just be a place where people go. And I think, as we heard in testimonies earlier, having that contact. So those safe havens, I think, are really important, and in the modern climate, maybe that's a place, but maybe it's also a place online that people can go to reach out for that help and support. Sometimes when we get the calls, it's because they don't know where else to turn, or they've tried other places and they're closed or not accessible. And we're happy to be here in times of crisis for anybody 24/7. But I sometimes think that we're not the best skilled service to be able to give the right level of intervention.
Thank you, and that connects to a couple of other points. Something that I hope you're aware of, you may not be, that the joint initiative between Surrey Police and Surrey and Borders Partnership Trust to support people with complex mental health needs has been shortlisted by the Health Service Journal as a mental health innovation of the year. So that sounds a really good example of partnership working. Yep. And there's some other comments about partnership working between the police and primary care, police and GP practices. So I don't know if you want to reflect on on those specific examples?
Yeah, and at acutes as well, because you know, I'm conscious that you know, when we have to do a detention, for example, the way the system works with our interface with acutes, we really need to do something differently there, because it's a traumatic time for people anyway, and to feel like the system is not progressing sort of speedily and quickly when you're amongst all of that other acute demand, I think is not a great place to be for somebody in crisis. So I'm particularly concerned about that. At the primary care and GP care level, I think there's more that we could do on that information exchange. You know, entirely appreciate the confidentiality issues, but understanding where some of that demand is and where some early interventions might help. You know, at a very practical level, if we've got a police community support officer providing a patrol in an area for some antisocial behaviour or to prevent a crime problem, it takes no time at all to knock on a door or pop up a few flights of stairs to ring somebody's flat doorbell to say, how are you today? If we could only do a bit more of that community level intervention, reaching out those connections, it might result in a referral, for example. So I think there's definitely more we can do with that very practical local activity.
That's great to hear. Thank you. So we're going to go back to somebody with bringing a national perspective now. We're going to hear from Andy Bell, who's the Deputy Chief Executive of the Centre for Mental Health, and also from Jane Bremner, the Head of Mental Health Commissioning in Surrey. And they're going to be talking about the really important question of how do we address inequalities in mental health, both in people's experience of mental health and their access to mental health services. So I think, Andy, you're kicking off?
I think so. Is that right, Jane? Let's say it is.
Yep.
Marvelous. So thank you, and really enjoyed listening to the conversation so far. My name's Andy, as said, and I work at Centre for Mental Health. If you don't know us, we are an independent organisation. We've been around for a number of years, and our work is all about using research and evidence to reduce inequalities in mental health and improve mental health for all. We were really lucky over the last year or so to work with Jane and a number of other people from around the country in what we rather grandly called a Commission for Equality in Mental Health. It was a piece of research to look at why is it that inequalities in mental health that have been around for so long, that have been known for so long, never seem to change? Why is it they remain so stuck and entrenched? And what can we do about that? And how can we build a system designed for equality? We published a final report last week, so this is our first opportunity, and I'm really glad that we're having it with you, because of course Jane has been part of this whole journey with us to test it out with people working in an area and see what you think, and hopefully you find that this resonates with what you're interested in, but also that you'll want to take up some of the challenges we've got as part of this. And I think what I've witnessed so far on the chat particularly is a real sense of a whole system coming together around mental health, people working in different organisations and different sectors with different roles saying, let's come together, let's share a purpose. And this is exactly where you can really kind of let rip and do some good stuff. So I'm going to take you through some slides, and I think if I say next slide, please. Oh, marvellous. Thank you to whoever is doing that. That's ever so kind of you. So let's start with the beginning. And crucially, I think we need to start with the notion, and it's a principle for us, that inequality isn't just simply a fact of life. It's definitely there. We know it's there, and I'll give you some of the statistics later if you don't know them. But the reality is that inequality doesn't have to be this way. We know that more unequal societies have higher levels as a whole of mental ill health. So the more equal your society, the better mental health is across the whole of society. And what we know is that inequality in and of itself is also toxic to mental health. So what we wanted to do is look at how can we create a society, how can we bring about the social, political and economic change that will give more people a good chance of having better mental health, literally mental health for all. And we believe this is entirely achievable with some changes at various different levels of the system. Next slide, please. So what do inequalities look like? Well, the statistics could just go on and on. I could spend my allocated time just reeling off awful statistics about mental health inequalities. So I'm just going to limit myself to two. We know, for example, that by the time a child leaves primary school at the age of 11, a child from one of the poorest areas, poorest households in any part of the country, including Surrey, will be 4 times as likely to have a serious mental health difficulty by the time they leave that primary school than a child from the wealthiest 20% of households. That's an extraordinary inequality. It dwarfs anything you see in any other areas, and it's a reminder of just how significant a factor that poverty is on our mental health. And then secondly, we know about racism, and again, I don't think anyone can possibly have pretended anymore that this doesn't exist, that we don't have systemic racism in the UK, just like any other Western nation. But what we know is that that has a huge effect on the mental health of people, particularly from African and Caribbean communities, but actually from a wide range of communities that experience racial inequality. Poor mental health always follows. And it's very serious, and indeed for Black people it leads to vastly higher rates of being detained under the Mental Health Act, for example, and indeed coming into contact with the police. We've just been talking about policing and mental health. Race is an element there that cannot be ignored. Next slide, please. So what we also found, and I think this is a really important point, is that for people's mental health, there's what we're calling a triple barrier. And what we find is that those same groups of people whose mental health is worse, whose determinants are, if you like, poorer than everybody else, those same groups of people often have poorer access to mental health support. And I don't just mean formal mental health services, I mean all kinds of mental health support. And we also know that when people get access to mental health support, that their experience turns out to be poorer. And guess what? The outcomes aren't as good as well. So the same groups of people are experiencing 3 different barriers all at the same time. And this then becomes very, very reinforcing of itself. Next slide, please. It will get cheerier, by the way, I promise. And then crucially, what we also know before we get on to some of the solutions is fundamentally inequalities in mental health are inequalities in society and our economy. And really there are 2 ways in which 2 lenses we can see this through, if you like. One of which does come down to wealth. Don't worry too much about the detail in the fancy graph at the bottom. What it shows you is that wealth-related inequalities, inequalities relating to income, to housing, to living conditions, they explain the vast majority of inequalities between different people in terms of their chances of having good or poor mental health. But we also know that inequalities relating to power in society, and privilege in society are also related to this. And we can see this in terms of certainly racism, as I talked about already, but misogyny, homophobia, people being at greater risk of violence, bullying in school, and being treated unjustly in all sorts of places. So again, we need to see that mental health inequality isn't just a thing that sits by itself. It's very much interrelated to these other things going on every day in our lives. Next slide, please. So what we wanted to do is think about, well, what would a system that was designed for equality rather than to go against it look like? And these are some of the key features that our commission with Jane and others came up with that we think are really important. I won't go into them in detail because again, we'll be here all day. But we know it starts in early years with effective programs that can help to give families and children the best possible start in life. Things like really good evidence-based parenting programs. It means having schooling which is inclusive, particularly of LGBT+ and disabled people. A lot's been talked about workplaces already, and sometimes when we think of work and mental health, we think of interventions, we think of training. Actually, the best thing you can do for mental health at work is treat people right. Workplace justice, good quality management, proper, appropriate ways of working. They're the things that help people's mental health at work. And we also need to think about reducing inequality as a whole, a fairer benefits system and fair access to benefits, of course. Good housing. Housing is such an important thing that many of the organisations on this call will be involved in some way or another. We've really got to take serious action on racial injustice. And we need to think about opportunities for an inclusive economy. I know lots of councils are now thinking about becoming living wage employers, and one local council we talked to had encouraged both the NHS trusts, both physical and mental health, on their patch, but also lots of other businesses to becoming living wage employers, and they've asked their supply chains to as well. And then you begin to get a really kind of virtuous train of events that can really help to take people out of poverty, and that will affect mental health. Next slide, please. So what does a system for equality look like at the local level? So first of all, we know that mental health is made in communities. It's not about our individual character. It's not about how strong or weak we are. It's not about whether we're resilient or not. It's about the communities we live in and the lives we live in. And many of the best examples we've seen of initiatives that have helped to reduce inequality in mental health come from within communities. They build up organically from people coming together, very often to provide mutual aid to one another, sometimes to take collective action because they feel they're not being treated fairly by the wider system, and very often about building a positive identity for a group of people that society doesn't treat too well. We also know that in supporting those, there's a key role for businesses, again, about being good employers, charities, particularly those with lots of money to spend, because some big charities still tend to use their money in very narrow ways. It's certainly about faith groups and other civil society organisations. They can all be part of beginning to change this. And we know we do need to make sure that funding is distributed fairly, particularly to marginalised communities. Many of these organisations are existing on bits and bobs of money that they scratch around for every year. It's such a waste of time and opportunity. Next slide, please. Local councils and indeed major public sector organisations run on this call, and we can all think about what we can do as part of a local system, particularly think about the anchor institution role, as I've already talked about, thinking about the role of schools and colleges, ensuring that people are connected now more than ever. That's so important for good mental health. But we also need to think about, remember the roles that councils have in supporting economic development, supporting creating a good built environment. Access to green spaces is really unequal. I was lucky enough to be involved in a piece of research published today to show that severe weather events have a huge effect on mental health, and guess what? And I suspect also heat waves, which are going to become a bigger thing in the future. Next slide, please. And then we looked, of course, at mental health services themselves, and again, that's mental health services in the broadest sense, and we came up with some principles. These are very closely aligned to a new national strategy called Advancing Mental Health Equality, which I really do encourage anyone involved in mental health services to look at and really think about how you're going to be able to implement that locally. I shan't go through this in detail because I want to move on to Helen. But again, it's about having mental health services that really meet everybody's needs. We've heard from far too long for people saying there wasn't a service for me, I was told it's not the right service, I was bounced around from one place to another, I was too ill for this, not ill enough for that. We've got to stop this. We've got to make sure there's something for everyone in an appropriate way. And we've got to make sure those services are accountable for reducing inequalities. We still have very, very poor information about how well services do or don't do in terms of reducing mental health inequality, and we can really change that. I think that's now my cue to hand over to Jane.
Well, I think there might be one more slide for you, Andy. Is there?
Is there?
Is there?
That's you.
Oh, is it? Oh, oh dear, is my screen not working? Jen, can you turn the...
I have moved it on, Jane. Can you not see?
I can't see. My apologies. My internet is clearly misbehaving.
It's the one focusing on data about inequalities in mental health in Surrey.
Great. I shall use my own. Sorry for that, everyone. My internet connection is clearly taking a...
Just at the right time.
Just at the right time. It's been perfect all summit. Anyway, thank you, Andy, for handing over to me and letting me relate some of the work that we've been doing in the Commission for Equality and Mental Health nationally, and how it corresponds to our world in Surrey. So we heard from public health colleagues earlier about our mental health need and what's driving demand and some of the social conditions and economic factors that are drivers of inequality here. So in Surrey, we know that men with a severe mental illness will die 22 years younger than other men in Surrey, and women will die 16 years younger. We also know that the percentage of adult carers in Surrey having as much social contact as they would like is far worse than the England average. And again, going back to the points around employment, we know that, again, people with a learning disability and in people who are in contact with secondary mental health services don't have as good employment rates as other people in other parts of the country. And thinking about children and young people, the percentage of looked after children whose emotional well-being is a cause for concern is higher than average here. So looking again at the recommendations from the rapid needs assessment, the diagram in the picture, Megan earlier told us that the pandemic has had a significant impact on mental health and well-being in Surrey, and it's shone a spotlight on the existing inequalities, so inequalities that we knew about already, and they are really stark in mental health. So the COVID-19 resident survey showed that some of the biggest impacts on mental health and well-being were reported by residents who were 16 to 34 and lower income families. So you look at where some of these aspects overlap or intersect, the impact on some young women with lower income is much worse. If you look at the recommendations from the rapid needs assessment, so one of them is address mental health inequalities, but if we look at some of the other ones, such as and improving access, and these will also play a part in promoting equality in mental health. Can we move on to the next slide, please, Jen? So thinking about the triple barrier of mental health inequality. So I just, again, want you to go back to the presentation by Edmund and by Emma today. So if you think back, Edmund on the video who went viral with his tweet, he clearly outlined to us the impact of living on universal credit and how his difficulties in getting work have impacted him, and the positive impact being in work has. As he said, it's not just about the money, it's about playing a role in society and being valued. And I think we've explored that really, really well today as part of the summit. And with Emma, I don't know, I certainly felt when I was kind of writing down how I felt if I'd been in her shoes, it's some of the words and feelings, it's quite despairing and quite worthless, really, was how I felt. So I'd like to invite you to think about how you felt during those sessions, those vignettes, about the commitment that you could make. So Jen, if you could turn to the next slide, please. If you could think about a commitment that would actually change the outcomes for people like Emma or like Edmund, thinking about their experiences. As Andy said, it can seem quite enormous. What can I do about poverty? What can I do about access to services? But small actions and steps can really make a big difference. So if you feel comfortable, if you could pop a comment in the chat, and I'll be quiet for a couple of minutes, see whether what chat comes through. But what you could do as an individual that would make a difference with regards to equalities in mental health. Brilliant. Some of the comments coming through are really, really good. The points on the slide were, guidance, if anybody, we're such a, a big group, a big system group in the room at the moment, that we can really, we can really all, if we do something, we can all make a difference. Thank you all for putting comments in the chat. It's really brilliant to read them all. I probably do have to move us on to the next slide now, please, Jen. So I think, in summary, it's the right time. COVID has shone a spotlight on inequalities, and we're here today, as was said at the beginning. It's as Jeremy Hunt said, it's the first time we've come together of late as a system in Surrey to do something about this. We can really, look at all the commitments down the side. We can all do something to take action on this, and it's possible. Again, as Tim said at the beginning, Surrey's made a commitment to empower communities to tackle inequality and make sure nobody's left behind. We have the structure, we have the structures in place across the system to do this, to facilitate change. And as evidence down the side, we can all play a part. I really think we can maximise the impact with all the knowledge, skills, experiences in the room. So I don't know, somebody said earlier about Edmund's story. All those individuals who tweeted, retweeted, got in contact with them, just showed how all the small actions can make a difference. And yeah, so I just want to conclude by saying it is just the beginning, and with a shared effort around mental health inequalities, but also around mental health in general, we can all take action to promote equality in mental health, and then make a difference. Jen, I think the next slide is just the references to the local Surrey data and to the national report. So thank you all. Thank you for participating in the chat. Helen, I shall go back to you.
Thank you both Jane and Andy. And yeah, and also thank you to everybody who's participated by putting their commitments in the chat. I agree with Jane, there's some really good things there, and they do illustrate that everybody has a part to play here. This is not just about the people who've got leader in their title. This is about all of us and the leadership role that we play in every role that we have. And our next and final speaker from outside Surrey is somebody who I've known in a leadership role and in various different leadership roles for many years, and somebody that I know is really passionate about making sure that everything that he does promotes good mental health, both in his staff and the people who access the services that he provides. So really delighted to have Rob Webster coming and speaking to us today to talk to us about the experiences in Yorkshire, and perhaps a bit of solidarity with Surrey, that some of the challenges that Surrey experiences, they're not alone. So over to you, Rob.
Thanks, Helen. Hi, everybody. It's good to see you all today and talk about this important topic. Hello, my name's Rob Webster. So I lead a mixed provider of mental health, learning disability and community services, which is South West Yorkshire Partnership NHS Foundation Trust, and I also lead the West Yorkshire and Harrogate Integrated Care System. And I've been asked to talk to you a bit about our experiences as an integrated care system, and also in terms of what we've been doing during the pandemic. And I hope that's okay. I've got about 15-20 minutes to do that, and I'll try and make it a bit interactive and give people enough space for a bit of a conversation. But just to start with a bit of geography, I guess. So West Yorkshire and Harrogate, it's not a real thing, is it? Harrogate's not in West Yorkshire, but it makes a sense as a set of places working together to improve outcomes for local people. And it's a big geography, covers 2.7 million people, 8 councils, 6 acute trusts, 4 specialist providers of mental health care, 300 odd practices, thousands of third sector organisations. And what we're trying to do as a partnership is clearly improve outcomes for local people. With that range of organisations that we've got, we've been very clear from the start that what we have to do is find shared points of agreement where we can come together around, and that's one of them. So the fundamental thing is we want to improve outcomes for local people. And then from the start in May 2016, we said, okay, where can we make the biggest difference? And where do we need to? And you're looking at the data, looking at what people tell us, you quickly get into a space that says that the mental well-being of people and the consequences of people with mental illness of being mentally ill are catastrophic for them and for their families and for the system. And at the moment, we've got, I just challenge you to step back for a second and just think about the system that we operate. So imagine a system where there aren't any beds available in the country for children. Imagine a system where psychiatric intensive care is full much of the time, and that we have to ship people hundreds of miles from where they live. Imagine a system where when you pop out of your bed, we put somebody else in it and hope that by the time you come back that we've got somebody else to put that person. Imagine a system where we constantly face stigma, and we have half the number of doctors in the north specialising in the issue as in the south. Well, that's the mental health system. That's what we've got. And it's catastrophic in terms of our understanding of mental well-being for families and people, because if you look at the facts, suicide's the biggest killer of young men, continues to be so. If you look at the life expectancy of people with serious mental illness, and of the 2.7 million people in West Yorkshire, Harrogate, about 1% of them will fall into that category. If you're a man and you're in that category, then your life chances are 18.6 years shorter. Your likelihood of having multimorbidity is greater, and your life generally will be poorer. One of the things we know about our clients is that if you've got a serious mental illness or if you've got a learning disability, you're probably not rich, and therefore you fall into the categories of other social inequality, which then also affect your life chances. So as a partnership, we're very seized upon the fact that we need to do something about it, and rather than being a partnership that just sits back and admires the problem, we've been setting out to do something about it. Now, we do have a partnership which is broad. It's got lots of organisations in it. It's got lots of politics in it. But what we do focus on is that things get dealt with as close to the person as possible. So if you can do it in their house, you should. If you can do it in their street, you should. If you can do it in their neighbourhood, you should. If you can do it in their place, you should. And you really only have to do it at West Yorkshire level if it passes a test really of scale. It's an issue of such scale that we have to do something. It's an issue of good practice. Somebody's cracked this, and we need to copy it. Or it's an issue that's a wicked issue. How do you deal with a situation where you only have 8 beds for children, and routinely you need 25? So on that basis, mental health is a significant priority, and mental wellbeing is a significant priority for our partnership. And I'm labelling this a bit because it's important for what happens during the pandemic. So from the start, our partnership, because it's eclectic, we take one of three. We have one of 3 perspectives on things. So sometimes we say, right, it's a mental health issue. Across the partnership, we have to do something about the fact that men are dying too often because of suicide. Sometimes we look at it as a place issue. We know that the treatment times for child and adolescent mental health services in Wakefield are really poor. So what are we doing about it? And sometimes it's a sector issue. The acute mental health providers across our area don't have sufficient beds always to coordinate. So let's coordinate them together. So our governance, which is really strong, works at system level. It works at place level, but it also works at sector level. And this is important because what we've put in place to deliver the improvements that we want to see can operate in providers, they can operate in places, but they can operate across the system. Just to give you a couple of examples of what that means. In Wakefield, all of the mental health providers have come together in the Mental Health Alliance. The CCG has given all of their mental health money, including the mental health investment standard to that alliance and ask them to deliver the outcomes that it wants. That alliance, which is hosted by My Trust, includes the third sector, IS providers, communities, and ourselves. And between us, we sort out the issues. The CCG gives us the staff that it used to have to do the commissioning of mental health to work with the providers. Now, on the back of that, child and adolescent mental health services in Wakefield has significantly improved, because rather than marking the homework of the providers, and rather than the providers being in competition with each other, we're collaborating around the problem and we're improving it with the capacity that we've got. If you think about that kind of sector level, as we've gone into new care models, again, I'll pick CAMHS, what we've done is say, we want to take the specialist money for CAMHS beds from NHS England, and we look after it. We want that to be connected to CAMHS services in places. So the provider collaborative have chosen a lead provider, which is Leeds Community Health Services. The four of us work together to service the beds and manage the money. The savings from that, which was about 500,000 in the first year, goes into buying more community provision in those places. So by having strong governance across sectors and having strong governance in places, we can collaborate on the things using that subsidiarity model that make a biggest difference. And the leadership, you'll notice in that, is distributed. So we operate on behalf of each other. So My Trust leads on the new care model for forensic services. We've got the money, we manage the service. Leeds Community Healthcare does it for CAMHS. Leeds New York Partnership does it for eating disorders, and we've got an adult eating disorder service set up. And we trust each other. We trust each other to represent each other, and we have good governance and we have good programme management underneath it. So in the first sort of 3 or 4 years of this, what we've been focusing on in mental health services is, let's look at the capital and the infrastructure that we've got. We don't have a CAMHS unit. It's only got 8 beds in it. We need 22. When the first bids for capital come out, let's get everybody, including the acute trust, the councils, and everybody else behind us, get a new CAMHS unit, and we've got one. It'll be open next year. So it was our biggest priority. We've been focusing on how are we sharing beds. It's ridiculous that people in Wakefield have to go to London to an out area placement or across the Pennines if Bradford's got beds. But we've got a difference in the way that the clinical models work, which don't allow us to access those beds. So let's focus on a single bed base so people don't go out of area. We've been focused on suicide prevention. We've been focusing on changing the models of care and then sharing the practice. So if you look at primary care mental health, sometimes we default to IAPT, but some people are not, some people aren't, it's not sensible to give them IAPT, it's not suitable, but GPs can't look after them, but they're not sick enough for secondary mental health services. So instead of putting services out to tender in Leeds when the IAPT contract came up, they worked as a collaborative to say, how do we fill that space between general practice, specialist mental health services and IAPT? How do we wrap IAPT into that and general practice and specialist mental health to give a joined up service? And as that's implemented, how does everybody else copy that approach? So that's what we're doing in the first few years. And then alongside that, if you look at the other programs that we've got, urgent emergency care, well, guess what? People have mental health crises. That's part of that program. Harnessing the power of communities. Well, communities can build resilience, so people are mentally well. So it's part of that program. Support for the 270,000 carers that live in West Yorkshire and Harrogate. Well, guess what? The mental distress caused by carers when services are fragmented and not joined up is significant, so it's part of that program. Health inequalities. People with mental illness face significant and enduring health inequalities. So it's part of that program. So we've infected that thinking. And what I would say to you, one of the key messages I would give to you is that if you think about mental health and mental well-being, sometimes you default to mental health in a silo, just as much as anything else. But actually, there's 2 roads to travel for mental health. There are specialist mental health services, but you've also got to look after the mental, physical, and social needs of people. And if you're doing that, then mental health is part of everything. Now, in February this year, it seems a very long time ago, we published our 5-year plan. We've published 3 plans so far. We've only been required to publish 2, but we've published 3 for the ICS. We've got a mental health strategy that supports that, a workforce strategy that supports it, and everything else. And the ICS strategy in February said, okay, of the 176 things we're being required to do by the centre, what do we think is important? Alongside what else do we think is important? And we came up with 10 big things. And the first 3 of those around health inequalities. And the second of them is about reducing the difference in health inequalities faced by people with mental illness. The 6th one is about reducing suicides. But then there are some, the 8th, 9th and 10th ones are about representative leadership. So people from different communities, people with different protected characteristics are represented in our system. Having good jobs for people, which again is a driver of good mental well-being, and making sure that we have a green economy and access to green space, again, a big driver of mental well-being. So mental well-being is shot through everything that we do. Now, when the pandemic hit, our ICS, quite clearly was potentially, you could say, would be sidelined, but it wasn't. So if you've got a command and control system through health, and you've got a command and control system through MHCLG, into local resilience forum and into organisations, actually the actions required are about systems. So having a system which brings together councils, the NHS and communities, because ours is an equal partnership, is essential. So we've been focusing very clearly on ensuring that the mental well-being of people during the pandemic is secured, and that the consequences for health inequalities are reduced in a period where they could be increased, and that we look after the mental well-being of our staff. And I'm not just talking about NHS staff, I'm talking about care staff, talking about voluntary third sector staff, talking about IS staff, I'm talking about everybody who works across this whole field. So the kind of things that we've been doing have been putting in place really practical solutions. So 24/7 crisis support, it's a scale issue. Let's get the scale going straight away so that we can give people access, irrespective of whether they're registered with mental health services or not. Just ring a number, you'll get access, you'll get signposted. Once we've done that, we realised that we could provide support for people who are bereaved. Because if you've been bereaved in these times, it's a very distressing thing, because you might not have seen your loved one at the end of their life and you might not have gone to the funeral. So we put in place specialist support for people who've been bereaved. Similarly, we put in place additional suicide prevention activities. We'll put in place additional suicide post-vention activities, because if you're affected by suicide, you yourself are much more likely to die by suicide. So putting that targeted intervention in straight away has really helped. So alongside those, we've put in place fast access and connection services for everyone who's shielded and for every family with learning disability and autism, so that people who were lost to services or didn't know how to enter them could get there. During this period, we've also seen significant pressure on our beds. So collectively, we've looked at how do we coordinate that and how do we buy independent sector capacity. We've managed the planning, the bidding and the money with the national teams to make sure there was always funding and always capacity and always a united front around the mental well-being of people. And we've ensured that we've provided support in places and mutual aid where it was required. Now, over and above that, we focus on our communities. So we're all aware that, that health inequalities have had an even bigger light shone on them by the pandemic. When the issues came out around Black, Asian and minority ethnic communities, we set up a commission to assess the work we were already doing in this space, chaired independently by Professor Dame Donna Kinnair, working with community organisations to challenge what we were doing, see if it was enough. And after 6 weeks, that came up with 4 sets of recommendations, and the 4th one was about mental health. What it said was that there's a disproportionate impact upon our Black and Asian communities around their mental well-being because of housing and access to housing, because of employment and access to employment, and language and other skills, other issues. There was an issue around stigma, and there was an issue around access to services. So we have to sort those out. So as an ICS, when you get the Public Health England report that says this is a problem, we say, well, what are we going to do about it? And if it says we've got to do something about employment, because we have an integrated care system where local government is an equal partner, and our local industrial strategy is seen alongside our ICS strategy, we can do something about it. And that's what we are doing. That'll be signed off by our partnership board, which is politically led. The actions will be signed off at the next meeting. Similarly, we've been working on positive messaging during terrible times. So rather than focusing on what you can't do, what the restrictions are, we've had a program called Unrestricted and Positive Vibes, which says you still can do things in your community. You can still see some people, you can still go for a walk, you can still get out there, you can still connect over Zoom, you can still have a takeaway, whatever it is. And that's been backed by something we've been running for a couple of years called Looking Out for Our Neighbours. At the back end of the previous year, we'd done some work on loneliness and tackling loneliness, and we talked about the fact that 20% of children say they're lonely. The majority of people over 65 are unhappy with the amount of social contact that they have. And with over 300 third sector organisations, because they're equal partners too, we did a big campaign about how do you just be a good neighbour? Because some insight had said, that's what we want. We want small acts of kindness in our communities that will demonstrate we're a good neighbour. Just saying hello, taking your bins out, checking in on people if you haven't seen them for a while, having a cup of tea. In the first phase of that, we reckon from Leeds Beckett research that 48,000 people got involved in small acts of kindness with their neighbours. And we just launched during the pandemic. Clearly, during the pandemic, if you took the Hollywood view of the world, what you'd see is that there's an outbreak of violence and society falls apart. What we've seen is an outbreak of altruism, which builds on this Our Neighbours work. And we've now launched a sort of, this phase that we're doing is talking about our neighbours during the pandemic. And we've got a series of Gogglebox style films which depict real people talking about the fact, I haven't been out since March, but my life is enriched because I've got a Zoom group that we put together with third sector support where we look after each other. And that kind of sense of communities, community assets, building on the work we've done will keep people more resilient and manage their well-being. And all of this is linked into our economic recovery plan. If we don't have good jobs for people, if the people getting those jobs aren't across all sectors of society, if we don't address the fact that Black, Asian and other ethnic communities find it more difficult to get jobs, then we'll be in real trouble. And as an anchor institution, as the banker, health and care will get money. We've got a real role to play in the mental well-being of our citizens, and we're really up for taking that role. During this period as well, the final two things I'll say is that we've been really upping our support for unpaid carers. There are 270,000 people who care for someone out of a sense of duty or love. That's more than all of the staff in health and care put together. And they're some of the most vulnerable people and some of the most deeply affected by the pandemic. So we've been putting in place a whole raft of support for our staff who are carers through working carers passports and enhanced support, and people who are looking after people who are shielded. And then we've also been putting in place through a HR hub and workforce, all of the best practice that we've got around mental well-being for our staff, who some of whom haven't stopped. People in ICU, yes. People in care homes, yes. Our district nurses and community staff, our staff in intensive home-based treatment out at 2 o'clock in the morning dealing with mental health crisis. People haven't stopped, and what they need is support. So we've curated that right across West Yorkshire. We have a health and wellbeing hub. We have arrangements in each of the places and each of the organisations that tie into that to make sure that people get the best wellbeing offers available, so that you build on good practice. So in my trust, when staff couldn't get food, we fed them. Because the supermarkets were empty, well, we gave them food, we fed them, we gave them drinks, we gave them extra time off. Other places have done similar work around mental well-being, access to psychological support, access to pastoral support. All of that is curated and continuously available, and not just for the NHS. So I guess I could keep talking, but I would say that in all of this, what we're building on is really firm foundations, because we've got good governance, we've got great relationships, and we've got clarity of purpose and ambition that's written down in clear plans. And it's backed by money, it's backed by people. So when things like COVID hits, we can respond, and we can respond in a way which makes a real difference and saves lives. And we're going to have to keep responding, because this isn't going to go away. And what I really hope is that post-COVID, all the work we did on digital, including digital exclusion, which happens to be a significant proportion of people with dementia, people on the edge of care, people who have serious mental illness, and so on. All of that digital work and digital inclusion becomes part of our normal practice. Clearly, we still have barriers to overcome all of the time and right across this agenda. But I genuinely think that we're building a platform here, and I hope that you're doing the same, and we can steal as many ideas from you as possible, where we can start really doing what modern health and care systems should do, which is looking after the physical, mental and social needs of people. Because when it comes down to it, that's what integration is all about. I think I'll stop there. I've got some slides which I'll pass on afterwards, which say all of this and provide you with some numbers and some pretty pictures. But I hope that's given you some clarity on what we've been up to.
Thank you, Rob. That's great. And you actually, in your last 30 seconds, you answered the question that I was building up to pose to you, which was, what is it that you think's created the conditions to enable you to do all these things in West Yorkshire? And you talked about the importance, which I very much recognise, of both good governance and good relationships. And I think you need those things to hold you when the going gets tough. I wonder if you could just talk for a moment or two about some of the times when the going has got tough, and how that having that good governance and good relationships has helped you through that.
Okay, I mean, I think it's pre-pandemic. We've had to make choices around things like, we've got four specialist mental health providers. We have to decide. We've got too many assessment and treatment units, so where are we going to put them then? Or we've had to really think about that, and ended up with 2 ATUs. That's been driven by clinicians and clinical needs. There's been disagreements along the way, but we've got to the point where we've understood that they need to be in Wakefield and in Bradford. So Leeds is going to stop providing that support and care. Some of the clinicians in Leeds don't like that, but collectively we stand behind it and think it's the right thing to do. During the pandemic, things have got really sticky, and we've had to ship PPE from providers of mental health into our acute sector colleagues at short notice, but we will, because we've got the right relationships and we've got the right governance around all of that. So I guess it always helps, and the pandemic has been a real leveller for that. And I'm sure you've all had sessions, I know Helen, you will have done, with Canterbury in New Zealand, and it felt to me very similar to their experiences around, they built something on good governance and good relationships. So when they had an earthquake, well, they could overcome it. When they had a terrorist attack, actually they could overcome it. And it feels to me like we're in the same kind of space at the moment.
That's great. Thank you so much, Rob. So Rob is our final presenter today. So I'm now going to hand over to Joanna, the Chief Executive County Council, who's going to kind of sum up the last 3 hours and talk to us about where we go from here. So thank you, Joanna.
So I should start, first of all, and say a huge thank you for everyone that has joined today at sort of reasonably short notice. But I think that sort of illustrates, I think, the shared commitment that we all have to improve mental health emotional well-being in all of our communities. And I think what we've learned today very sort of clearly and strongly, it isn't about a single institution or organisation. I think what we've heard sort of very powerfully from all our speakers, that this is a joint endeavour. And actually the thing that would make most difference is how we can get upstream of a number of issues that can sort of catapult people into poor episodes of mental health, that we do more together to prevent those things, to recognise the importance of good mental health, to sustain our families, our lives, to be able to thrive in education and work. So for me, it was genuinely humbling to have so many people want to attend. I'm truly grateful to the speakers. It was great to have Jeremy Hunt with us. I always listen in awe to Rob, who I think brings a really interesting perspective always, but I think really sort of compelling arguments about joint working. I know that many of you will remember for a very long time the words of Emma and Edmund. I mean, very difficult to hear in a way, because it sort of seems unconscionable that, you know, these things happen. People, in Edmund's case, you know, live in a way that, you know, what one sort of reach out can sort of generate all that response from around the world. I remember reading about it in the paper. I mean, it's incredible. And it is those small acts of kindness that can make such a difference. But it is also knowing, say in the case of Emma, we've got to, as a group of partners, make the sort of systemic changes to ensure that people can sort of grow and live great and extraordinary lives. And absolutely, that is my commitment in my role. And I hope many of you will join me in making that commitment to genuinely change the lives of people that live here in Surrey, to address the inequalities that we feel, and to make it a place that people can sort of work and thrive with their mental health. So it's good to hear from Mark Britnell, a perspective from around the world, but actually the wider responsibility that our employers, our businesses have, and the impact that great employers can make on great well-being as well. This was just the start. I know that there were many comments in the chat box. I know that many of you would have wanted to be in real rooms, meeting people, talking about the issues like face-to-face and coming up with solutions. And it's really difficult that we haven't been able to do that, and quite difficult, I think, to sort of run a whole series of virtual breakout rooms. But I know from the chat, from side chats that I'm seeing as well, that I think we do have a sort of shared understanding of the issues that we've got to face together. I think we've got a huge commitment from you all to make things different. And I think my mission with colleagues from across the piece now, with our elected members, with board members, with service users, those with lived experience, to sort of turn all this understanding and knowledge into a sort of a real and sort of deliverable plan that we can sort of look at in 2 or 3 years' time, maybe longer on some issues, and think actually this day was the start of something truly different. So I think this is a beginning, building on lots of good things that I know we're doing in Surrey, like meaningfully doing. But the pandemic has, I think, sort of changed immeasurably the lives of some of us, and the gaps are wider. You know, money is going to be tight, I think, going forward. So we've got to come together, agree how we can make things better, and commit to that. So I will work with many of you to bring that to a reality. So I won't talk in detail about next steps. We do have some to think about, and I will make sure that we sort of communicate that, and that this is the start of a number of other conversations that we should lead. So I will pause then. I hope you got value from the session. Again, I would thank all the speakers that offered their time, including Gavin, and I would pay a special thank you to colleagues down the corridor, Jen, Emma, Justin, who I think with trepidation have been running this Zoom arrangement. It's been sort of a bit precarious with our sort of network here, but we've made it through. So I hope you go off, reflect on what we've heard today, think about what you could do, and let's do it. So thank you.
Thank you.